Hi, everyone. This is Dr. Weaver. I just wanted to go ahead and do the voiceover on adrenergic blocking drugs as promised. So let me go ahead and start sharing. I'm going to try to make this as short as possible. So there are certain parts of this that I will allow you guys to go ahead and take a look at. Um, Entire screen. All right. Let's see. That should. I'm not sure if that's sharing yet. All right. Let me try to share again. This particular Teams is a little different than what I'm used to. So let me see. Let me try this. I'm not really quite sure if it's really sharing. It usually puts like a red looking border or something um, around what I'm sharing. So let me stop again. I just want to make sure you guys are able to see what I am sharing. Um, let's see, what does that look like in display? Uh, nope, that's not what I want. That's what I want there. All right. I think it's sharing now. Yeah, I would hate to go through much of this and realized that it didn't share what I wanted. Uh, all right, so let's go ahead and jump into it. Let me go ahead and expand that. All right. So as you guys can see here, um, we are doing a pharmacology, a clinical pharmacology, and in particular, the topic that we will be looking at today or discussing would be adrenergic blocking drugs. All right. Remember, the other day we did adrenergic drugs. So the adrenergic drugs is what actually stimulates. Right, it mimics the that fight or flight response, but the adrenergic blocking drugs, it essentially blocks that response. All right, and not necessarily it doesn't necessarily bring about the parasympathetic response. It's just actually blocking the sympathetic response, if you will. All right, so I don't want you to be confused about that. Let's see if I can. Um, I guess that doesn't work. Anyway, so let's take a look at the learning objective. So list the four types of adrenergic blocking drugs. So thankfully, we only have four to look at. Explain the uses, general drug actions, general adverse reactions, contraindications, precautions, and interactions of the adrenergic blocking drugs. And I know we're kind of midway into the semester, but sometimes these different terms that I just mentioned and I should have mentioned this even before, or in the beginning, when we first started in the course regarding pharmacology. Go back and look at those different definitions. For example, what does it mean by drug actions? What does it mean by general adverse reactions versus side effects? What does it mean by contraindications? I mean, it may appear that it's a given, so to speak. That might be for some, but for those of you who are not familiar, it might be helpful for you to go back and look at these different terms and define them. It's the same when you guys are reading the different chapters of your readings, and it provides you with some terminology. And I think it provides with some definitions of those terms as well. It would be important for you to take the time and go through that terminology and understand it well enough so that as you do your readings, you will understand what the writer or author is trying to bring to your attention. So I would definitely take the time to do that, and it shouldn't take long at all. Um, Distinguish important pre-admission and ongoing assessment activities the nurse should perform on the client taking adrenergic blocking drugs. Taking an adrenergic blocking drug. The fourth one is list nursing diagnoses particular to a client taking an adrenergic blocking drug. And lastly, examine ways to promote an optimal response to therapy, how to manage common adverse reactions, nursing actions that may be taken to minimize orthostatic or postural hypotension, and important points to keep in mind when educating clients about the use of these adrenergic blocking drugs. I don't know why this doesn't quite share my entire screen. That's really weird. Anyway, so let's take a look at so as you guys know, since we went over the adrenergic drugs the other day, some of these slides are just a repeat of the system that we are dealing with, and that is the nervous system, or in this case specifically, the autonomic nervous system. So as you guys can see here, this is the division of the peripheral nervous system that is concerned with the functions essential to life of an organism, of an individual, and not consciously controlled. You don't control your blood pressure or your heart rate in a way, for the most part. Gastrointestinal activities, your body automatically does these things. And the nervous system is involved in that process. And so we realize that the autonomic nervous system, or ANS, is actually divided into two branches. That is the sympathetic branch. This is when things are stimulated. And as you can see here on the right side of this picture, it tells you the physiologic or the body's response when the sympathetic branch is at play. And of course, the other one is parasympathetic nervous system, or parasympathetic. And look to the left of this image, and it tells you essentially how the body is responding to this type of stimulation. And for example, as you guys can see here, as far as pupils are concerned, under the parasympathetic nervous system, they will be constricted, right? Because you don't. The reason why the pupils are more dilated on the parasympathetic, excuse me, on the sympathetic side, is because if that person is going to do that fight or flight, you have to be able to see, right? So those pupils open wide, so you can see where you're going and go where you're looking and so forth. So and for example, the on the sympathetic side, of course, you would get an increase in the heart rate. But on the parasympathetic side, the heart rate should go back to pretty much normal. And as you all have also noted in class, the parasympathetic system is that rest and digest, and the sympathetic nervous system is the fight or flight. Remember, we cannot be in the sympathetic, we cannot have that sympathetic stimulation forever. You know, it will wear our bodies down, right? So it's like that balance. And the sympathetic nervous system does kick in certain instances, be that illness and disease, but also with exercise. The sympathetic nervous system kicks in. Sometimes when we're anxious and nervous and whatnot, not necessarily a disease or disorder, if you will, but it's how the body responds to this sympathetic stimulation. So hopefully that gives you a pretty decent idea of what I'm saying to you, right? So this chapter, in this chapter, we continue to discuss or our discussion of the sympathetic branch of the autonomic nervous system and what happens when the nerve impulses are blocked. So that's what our focus is on this particular one. We're looking at what happens when that sympathetic nervous system or stimulation is blocked. Trying to see if I can increase. Oh, there it is. Didn't do that before. All right. So as far as the autonomic terminology, norepinephrine is the primary substance that transmit nerve impulses across the sympathetic branch of the autonomic nervous system. This is one of those catecholamines that is at play when the sympathetic nervous system is activated. Now, activation of these nerves is sometimes called, again, a fight or flight, but it also refers to the freeze response. I don't think I've ever heard of the freeze response. It's usually fight or flight. Now, drugs that facilitate or that help in the transmission of norepi can be found in, it looks like chapter 23, but we should be going over some of those as well as we get further into the discussion. Now, in chapter 23, you learned that the classes of drugs were called sympathomimetic or adrenergic. All right, you can use those terms interchangeably. Now, in this chapter, the drugs that prevent the response are typically called adrenergic blocking. So we're blocking that response. Now, two additional drug terms that are less frequently used are the anti-adrenergic or sympatholytic. That lytic meaning it's something is being destroyed, right? Um, because again, these agents block the transmission of norepinephrine in the sympathetic portion of the autonomic nervous system. So also take a look at box 24 1, and actually that'll be on the next page as well. All right. So before I go to the next screen, so with the sympathetic nervous system, as you can read here, nerves are stimulated when the body is confronted with a stressful situations such as danger, intense emotion, or severe illness. All right. It is, we did mention the fight or flight or freeze response. Um, it controls the individual's heart rate, their breathing, and the ability to divert blood to the skeletal muscles. All right. Because remember, in that fight or flight, the muscles are going to need oxygen and nutrients in order to respond to this sympathetic or whatever the situation is that brought it about. It is the person is going to have to be able to fight or run, and so the muscles need to be um, nourished and provide oxygen and so forth in order to carry that out. All right. So the adrenergic blocking drugs, and as far as the actions are concerned, so essentially what's happening is that block neurotransmission in the sympathetic nervous system directly. Of these drugs block the neurotransmission in the sympathetic nervous system directly by essentially blocking the receptor or by indirectly preventing the release of norepinephrine. So, what do we mean by that? All right. So, think about the heart, right, as one of the organs in our bodies that has receptors on it. All right. So, remember, I told you when these catecholamines like epi and norepi are released, they have to find their way to the heart, but more specifically, the receptors that are located on the heart, right? And when these catecholamines engage or stimulate or occupy even those receptors, it brings about the increase in heart rate in the case of the heart, that is, right? So what these drugs do, right? So the drugs, when we administer these drugs to patients, it is these drugs, these blocking agents, right? Like beta blockers, that will occupy those receptors that are located on the heart, right? So these drugs will occupy that space first, if you will, right? And so when the catecholamines are released, and they find their way to the heart, and more specifically, again, those receptors on the heart, they will find that there are no vacancies. Think about a hotel, right? So if those receptors on the heart are not occupied, then there's a vacancy, right? People can come and check in to the hotel, buy a room, and all that. But when there is not a vacancy, what does the hotel attendant that sign they put out there? They say no vacancies, and so essentially, with a blocking agent, or when these receptors are blocked by these drugs, and the catecholamines are released, right, and they find their way to the heart, then what they find is there are no vacancies, right, and so the body does not react with that sympathetic stimulation. In other words, you won't get an increased heart rate. Why? Because those receptors are blocked. All right. Someone else has taken up residence. And who is that someone else? Those blocking agents, those adrenergic blocking agents. So hopefully that will provide you with a better understanding as to what's going on. And this is what's going on as well with some of the other organs that when we talk about these different receptors. Um, not only does these drugs occupy those receptors on the different body parts, but there's also drugs that can prevent the release of the epinephrine. Right, so you're either going to prevent the release of these catecholamines, or you're going to block the receptors where the catecholamines are trying to find and occupy, right, and bring about those reactions that you normally see in the sympathetic with that sympathetic activity. Now, in box 24.1, look at the different terms here. The sympatholytic, all terms meaning to stop the neurotransmission. Well, all of these, of course, sympatholytic, anti-adrenergic, or adrenergic blockers. They're all used pretty much the same. Some of the terms I've just used more frequently. So all terms meaning to stop the transmission, a neurotransmission of norepi along the sympathetic branch of the autonomic nervous system. All right. Now, from the last chapter, we know stimulation of the alpha adrenergic nerves result in what? Vasoconstriction. We're talking about the arteries, for example. Now, if stimulation of alpha adrenergic nerves is interrupted or blocked, the result is going to be the opposite. Not vasoconstriction, but what is the opposite of vasoconstriction? Vasodilation. All right. And of course, you will get a lower blood pressure because the blood vessels are more dilated. Now, alpha adrenergic blocking drugs produce the direct opposite effect of the adrenergic drug with alpha activity. Now, drugs used in this category cause vasodilation by relaxing the smooth muscle of the blood vessel, namely the arteries. All right. Now, alpha adrenergic blockers are used primarily in ophthalmic preparations, those who, the eye specialists or these eye procedures. And what they do is they constrict the pupil, and these are discussed in another chapter, something that we won't be discussing, at least at the moment. Now, take a look at the various adrenergic blocking drugs. You have the alpha adrenergic blocking, which we just mentioned with respect to the blood vessels. You have the beta adrenergic blocking drugs, and of course, your beta blockers, your beta adrenergic receptors located on the heart. And of course, then you have both the alpha and beta blocking. And remember, those are your non-selective. Well, actually, if it's one or the other, it's selective. But if it's one, if it's, let's say, an alpha drug and a beta, then it is a non-selective. All right. And then you have the centrally and peripherally acting um, anti-adrenergic drugs. All right. Right. So drugs neurotransmission in the sympathetic nervous system may work directly, again, by blocking the receptor or indirectly preventing the release of the norepi. And that's something I've already mentioned. These drugs are clustered into, of course, as you can see again, the four different groups. Now, the alpha adrenergic blocking drugs, these are the drugs that block the alpha adrenergic receptors. These drugs produce the greatest effect on the alpha receptors of the adrenergic nerves that are the control of the vascular system. So again, we're talking about the vasculature, right? The beta adrenergic blocking drugs again controls the heart. Right. And then you have the alpha and beta blocking drugs. They have an effect on both. So both the heart as well as the blood vessels, right? The arteries, again, in particular. As far as when we talk about centrally and peripherally acting anti-adrenergic drugs, these are drugs that prevent the release of the neurotransmitter, the norepi. So this is what we were talking about, how it'll either block the receptors or it'll stop the release of the norepi. Now, these drugs block the adrenergic nerve impulse in both the central and the peripheral nervous system. Remember, the central nervous system is the brain and spinal cord, and everything else outside of that will be your peripheral nervous system, to include the autonomic nervous system. All right. I think I showed this to you all in class. It almost makes me feel like we're talking about the same things, in which we really are. But this is kind of some reinforcements, right? So take a look at the alpha adrenergic blocking drugs, their actions. They interrupt or block the adrenergic nerve stimulation that results in vasodilation, right? Because if the catecholamines were to, that epi, norepi, if they were to stimulate those receptors that are located on the blood vessels, we would see vasoconstriction. But in this case, because that impulse is being blocked, we're going to get vasodilation. We want that in some of our patients, especially, let's say, if you got a patient with hypertension. We want this type of drug because we want to lower the patient's blood pressure. Someone comes in with a blood pressure, or they usually walk around with a blood pressure of, let's say, 180 over 120. Well, we want those blood vessels to dilate so that that blood pressure will drop. Remember, vasoconstriction causes blood pressures to increase because of that decrease, or that smaller diameter of the artery is more resistance within that narrow or a smaller artery, right? And of course, when the blood vessels are dilated, there's less resistance, and so you get a much lower, or you get a lower blood pressure in that sense. Right. Now, basal dilation occurs through relaxation of the smooth muscle of the blood vessel. Remember, I showed you in class, that you got these three different layers of the artery. Well, that middle layer is the smooth muscle portion of the blood vessels, and so that is where the receptors are, and that is what the what is it the catecholamines stimulates those receptors that are located on the smooth muscle part of the artery. But if we block them, then the catecholamines, epi nor epi, will not be able to stimulate those receptors. And so we get vasodilation instead. Oh, and as you can see here, this is the normal diameter. When I'm talking about diameter of the artery, how large that circle is? And then, of course, this is the normal lumen. We say lumen or size of the artery. This is a normal size. This is when this muscle part that has the receptors, when they're stimulated by the epi, they contract, as you can see here. See how it's gotten smaller. So you would expect to see a higher blood pressure here. All right. And over here, after we give the drug, we get this vasodilation, meaning that the blood pressure is going to drop. Hopefully, you guys can see my cursor here. All right. So this is the vasodilation effect that we're trying to get here. So I think that's a nice demonstration. Take a look at some of the uses or why we use this particular drug, the alpha adrenergic blocking drug. We use it for hypertension that is caused by pheochromocytoma. These are tumors that are located on the adrenal gland. All right. Hypertension during pre-op preparations. Sometimes patients, they become hypertensive and you don't want to take them into an OR, with hypertension. So we give them these drugs in order to lower that blood pressure by dilating those arteries. Reduce ocular pressure during laser surgery. You guys have heard of, for example, glaucoma. That's when you have an increase in pressure in the eye itself. And of course, this drug has a way of decreasing that pressure. Also, it is used to prevent or treat tissue damage caused by extravasation of the drug dopamine. So when you think about the drug dopamine, dopamine causes the blood vessels to constrict, right? Now, as long as that drug is in the vein, then you're fine. But because it will just cause the veins to constrict and thereby increase the blood pressure. This is why we give dopamine. Somebody might be in shock or something, or for some, the septic shock or what have you, or some other condition that causes the blood pressure to drop. And so we use the drug dopamine. It's an inotropic type of drip, but what it does is it has some activities of inotropic, meaning it helps the heart to squeeze, the muscles to squeeze. But sometimes the IV slips out of the vein for whatever reason, and it is in the tissue, and you don't quite know it at the moment, but that drug is being administered through the patient's tissues. Now, within the patient's tissues, surrounding tissues where the IV is located, um, the um, the this drug dopamine causes those blood vessels to vasoconstrict. Well, when that tissue vasoconstricts too much, then you don't get blood flow to that tissue area. And of course, necrosis can set in, ischemia, necrosis. And so what we do is we give a drug called Regitine. Regitine acts like an alpha adrenergic blocking drug where you want to, or locally, you want what you're trying to do is vasodilate of those blood vessels so that the patient gets more blood flow to the area. They use like a subcutaneous needle, and they just they inject the needle of the skin all around the IV site in order to hopefully um, open up those blood vessels. And we call it extravasation because it actually destroys the skin, the subcutaneous tissue, and so forth. And so we hope to prevent that. All right. Now, some of the adverse adrenergic blocking drug adverse reactions. These are some of the common ones. The patient can experience weakness, The patient can also experience orthostatic hypotension. What that means is when a person goes from a lying position, we take the blood pressure, and they go from a sitting position, we take the blood pressure, and then they stand, we take the blood pressure. And you don't want the blood pressure, especially the top number, the systolic number, to drop more than 20 points. So sometimes when you give this drug, that the numbers can drop more than 20 points. We say 20 millimeters of mercury, but it'll drop that top number. Say that top number goes from 120 to like 90. Well, that's a 30-point drop, but it has dropped more than 20 points. And so we call that, orthostatic hypotension. The danger of this, of course, is that people can become dizzy and the blood pressure can really get low. They may injure themselves and so forth because their blood pressure is very low or can get very low. These drugs also cause cardiac arrhythmias, abnormal heart rhythms, hypotension or the regular hypotension that doesn't involve the three positions where we take the blood pressure. It can also cause tachycardia because once that blood pressure drops, let's say somebody goes into hypotension, then the heart rate is going to increase as a compensatory mechanism, or the heart rate will try to increase in order to get more blood flow out into the body. Because when the blood pressure really drops significantly, then your mean arterial pressure or your MAP that I talked about, it also drops, and so you're not perfusing your tissues and organs. And so this is a compensatory response from the body to say, I need to get more blood out there in the systemic circulation. And also other drug-specific adverse reactions, which I think we should see some of that as well as we go through this. All right. As you can see here, hypersensitivity for contraindications are always, as with most of your medications, one of the things to look for. Also, it's contraindicated in coronary artery disease. This is when the arteries in the heart is just full of plaque, and so this drug will be contraindicated in that. It could that buildup of plaque can affect blood flow through the heart's arteries if the blood pressure drops too much. So it is contraindicated in coronary artery disease, meaning we don't want to give it at all. Now, when it talks about caution, right, use cautiously in clients with, that means that we can give it, but we just have to really be vigilant in assessing these patients. So as you can see, pregnancy, lactation, that's always the case, it seems, most of the time at least. Recent myocardial infarction, renal failure, and also Raynaud disease. Raynaud's disease is a condition where the blood vessels, usually in the fingers and toes, constricts excessively. All right, and it does so in response to when it's cold or if there's a lot of stress, right? And because of this vasoconstriction, it does reduce the amount of blood flow to the extremities, and it causes the digits, if you will, the hands, if you will, to turn actually white, blue, and purple. And this is due to that lack of oxygen and blood flow to that area because of the vasoconstriction. All right, and of course, once that episode ends, blood flow resumes to that area, and then the natural color comes back. So, not that we're studying Raynaud's now, but um, your book talks about it, and of course, I want to give you an idea of what it's talking about. It's a vascular disorder. You don't want to reduce. First of all, if you got this vasoconstriction that is taking place already, um, drop the blood pressure with these blocking agents. You got the constriction going on with the disease, and then you're dropping the blood pressure with these particular drugs. And so blood flow to that region can be even the more compromised or interrupted. All right. And of course, go ahead and read your interaction table. Those are fairly easy to read. All right. Um, all right. So remember, we just talked about the alpha adrenergic blocking agents. So that's the blood vessels in particular. Here we're talking about beta adrenergic blocking drugs. And of course, we're talking mostly in this case, we're dealing with the heart, right? There's decreased stimulation of the sympathetic nervous system on certain tissues, of course. Um, it blocks the nerve impulse from jumping this synapse area and continuing to the adjoining nerve ending. And let me show you basically. This is a synapse. This is a space between the nerve itself. This is a nerve, and this is the organ, of course, that is going to stimulate. So I want you to think about this that I have my cursor kind of moving over. Think about several of these that are in a like a line, right? Before you actually get to the actual organ itself. So what happens is when it talks about on the previous page, let me go back, where it talks about block the nerve impulse from jumping the synapse area. What it's basically talking about is um, these are the synapse areas, right? And it goes from one nerve to the next nerve to the next nerve to the next nerve until it gets to the organ itself. So again, just think about uh, several of these leading to the organ itself, and between these nerve cell membranes, if you will, um, between them you got the synapse space or areas, right? And so the beta adrenergic drugs actually blocks that transmission. It doesn't allow it to jump over to the next nerve. All right. So hopefully that kind of gives you an idea of what I'm talking about. Kind of go back. Actually, I went too far. All right. So there's also decreased excitability of the heart. So when the heart is not really beating very fast, then what you're doing is you're decreasing the heart's workload. See, when the heart is beating very fast, then the workload is increased, and when the workload is increased, it requires more oxygen. So when we give these drugs, it decreases that excitability by blocking those nerve impulses, and we get a lower heart rate, meaning the heart is not working as hard, meaning you have less oxygen requirements for the heart. All right, and so that's what it means there. All right. There's also decrease in the heart rate and dilates the blood vessels, and so that's what the beta adrenergic drugs does, and especially it decreases the heart rate, so you get a decreased workload of the heart. When it is used for glaucoma, it reduces the production of aqueous humor in the anterior chamber of the eye. So the eyes, when there's an increase in aqueous humor, it's a solution in the anterior chamber of the eye. When that aqueous solution increases in amount, that's what causes glaucoma, that increased pressure, right? And so what this drug does in this instance is it reduces the production of this aqueous humor, and therefore you get less pressure in the eye, which you want, because when that pressure in glaucoma goes up too much, someone can actually lose their sight. Some of the example drugs that we talk about here are the LOLs, or the laugh out louds, atenolol and metoprolol. These are the old laugh out loud, right? So those last four letters, all right? Right. Now, as I said before, these drugs work by blocking the nerve impulse from jumping the synapse area. Again, what I was showing you is that just imagine several of these that is leading, let's say, leading to your heart. for example, and those impulses have to jump this synapse space, and it keeps jumping from one nerve to the next nerve to the next nerve again until it reaches the organ itself, which is what you see here, what is demonstrating. All right. So these blocking agents actually stop that jumping, right? And so you get less of a response because they're being blocked. All right. Let's see. All right, so I pretty much talked about that. Now look up the different uses for this drug. We use it in hypertension. And of course, this is a first choice with a stable angina. Some angina, which is chest pain, intermittent chest pain, can be um, unstable, but this is one of the stable ones. But I won't get into all that. But anyway, so it's talking about the drug is used for those with hypertension. It lowers the blood pressure because it dilates the blood vessels. It also is used for cardiac arrhythmias. Of the ventricular or supraventricular tachycardia. And that's just talking about people who have abnormal ventricular rhythms, like ventricular um, tachycardia, right? Meaning it looks like a lot of W's, right? And the heart is just beating very fast, and so you have a decreased cardiac output as a result. When it talks about supraventricular tachycardia, supra meaning above the ventricles, meaning the atria, there's certain abnormal heart rhythms like atrial fibrillation, atrial flutter, that we'll probably talk about later on. But anyway, so that's what this drug is given for, those types of cardiac rhythms, because they can slow down that heart rate. Migraine headaches, heart failure, it's used for heart failure. Because again, we don't want the heart working too hard when it's already sick. When someone has heart failure, they have a sick heart. So we want to decrease the workload. So we'll block that stimulation, that sympathetic stimulation, so that the heart is not working too hard. So because when that stimulation occurs, you got an increase workload, but you have very little oxygen supply. All right. Then it's also used in angina pectoris. This is just angina or chest pain used in glaucoma. It also prevents reinfarction in those with a recent MI, because if the heart has to work too hard, this individual can develop another heart attack. And so what this drug does is it prevents that reinfarction. All right. Um, and of course, it provides us with an alert that is worth mentioning. We discontinue these drugs slowly. In other words, we taper them. We do not stop them abruptly, because then the patient can have a very opposite response, and that is not what we want. I did provide you with some information about how beta blockers work in migraine, so just take a look at that. Try not to read everything or go over everything, because I'll be keeping you too long. Some of the general reactions, and you'll probably hear me being a little more detailed because I want you, when I discuss certain aspects of this topic, I want you to see why, and so you can kind of do away with some of that memorization and understand why it does what it does. So orthostatic hypotension, because remember you're dilating blood vessels, right? So you get that orthostatic effect. Bradycardia, because remember, if someone has a high heart rate and we give them a beta adrenergic blocking drug, we're trying to decrease the heart rate. Ideally, we want that heart rate to be between 60 and 100, and that's normal, right? However, sometimes that heart rate goes below 60, which is bradycardia. That's kind of one of the side effects. Dizziness and vertigo is possibly coming from the blood pressure dropping, or even a heart rate dropping, because it will drop your blood pressure, right? Bradycardia will drop your blood pressure because your heart is beating like lumped up, like maybe 30, 40 beats per minute, right? Or under 60. And so you're not getting that much blood out into that systemic circulation. And as a result, people get dizzy, right? Because you're not perfusing your brain and you get dizzy. You're not perfusing your muscles, right? Also, headache and bronchospasms as well can occur, right? Now, something also worth mentioning when we talk about beta adrenergic blocking drugs, beta blockers, they can cause bronchospasms by blocking the beta 2 receptors in the lungs. All right. So you have beta 2 receptors in the lungs, and sometimes when they're blocked, um, all right, that's not a good thing. See, normally beta 2 receptors are responsible for relaxing the smooth muscle in the airway, in the bronchioles. Remember, the bronchioles also has smooth muscle. All right, and when these beta two receptors when they dilate, they allow air to go in and out of the person's lungs. When the beta blockers block these receptors, it causes the smooth muscles in the bronchi to constrict. All right. And this leads to a narrowing of the airway, and it can cause the person to have difficulty breathing because of the spasming of the bronchial smooth muscle. So it's difficult for air to go in and out. Some of these beta blocking drugs have that property in it, where some of these drugs affect the beta 2 receptors in the lungs. I think Inderol is one of them. All right. And so we have to be careful about. In fact, they usually don't get patients like that. If someone has a history of asthma, they won't give them these types of beta blockers because it can cause them to go into respiratory distress. So that's something very important for you guys to keep in memory. You don't see it now. You'll certainly see it at some point. These are some of the GI reactions. These patients have hyperglycemia. Um, they also have nausea, vomiting, as well as diarrhea, some of your general responses. Not really sure how hyperglycemia, because typically when the sympathetic nervous system is at play, the blood sugars will increase because the body needs that glucose for energy. But I'm not sure how this is the case. I wonder. It makes me wonder: is it hypoglycemia? I mean, you know how these books are. I'm going to do a Chat GPT check on that and see what it says. But um, yeah, something about that one. It doesn't seem right. I'm gonna uh, color that red so I can go back and look at it. Yeah, something about that just doesn't seem right. Right. Let's see. All right. Um, Contraindications, known allergies to beta blockers, that's a hypersensitivity. And we also do not give it when someone has sinus bradycardia, meaning their heart rate is less than 60. You give it to them, and their heart rate is going down even lower. And so now you're going to have a cardiac output problem. Second and third degree heart block, we have to, I won't go too much into that, but suffice it to say for now, with these blocks, it causes the heart rate to decrease, and sometimes it can be lower than 60 beats per minute. Again, remember, we want 60 to 100. Also, in emphysema and asthma, remember I said that with these drugs, you have to be careful, especially if they have that particular beta 2 receptor that causes vasoconstriction of the bronchioles. And also, we don't give it to patients when they have hypotension. All right. It says we have to use it cautiously in folks with diabetes, thyrotoxicosis. Remember, with thyrotoxicosis, um, so let me explain this much to you. All right. So you guys know when someone is a hypo or is having a hypoglycemic response, they get very nervous and they get agitated and really jittery. The heart rate is increased. They get confused and so forth. Um, if I give this patient a beta blocker, right? The beta blocker is going to mask or lower the heart rate when someone is having a hypoglycemic response. So if it masks it, you won't be able to treat it because you don't know what's going on. If we know typically when someone has a hypoglycemic response that the heart rate is increased and they're confused and they're nervous and anxious and all that, then we have to be really cautious that when we're giving these drugs, that this patient doesn't have, it's not experiencing a hypoglycemic reaction because, if the drug um, keeps the heart rate and everything down, it stops the production, if you will, of some of those. The sympathetic system or the catecholamines, if you will, then we wouldn't know if the patient is really having a reaction. The thyrotoxicosis, the same thing. Remember, with thyrotoxicosis, that particular condition is associated with hyperthyroidism. And remember, in hyperthyroidism, the heart rate is usually up. So if I'm giving the patient this particular drug for some other reason, right, some other cardiac reason, it is going to cause the heart rate to be lower. And you probably won't know that these patients are having a thyrotoxicosis reaction or response. A response, and so we won't be able to treat the hyperthyroidism in that particular case. All right. So, and I did provide some information about that for you to take a look at. I think it's worth really taking a look at and seeing why it should be used with caution with these conditions. So take a look at the interaction table. I'm going to skip those two. It's actually two of them. All right. So let's look at so these are your non-select, because remember, whereas non-select, if it does one and the other. Remember, because if it's some of you probably didn't hear me say this, but think about it like X and Y. X, X or Y, or alpha or beta, when the drug has that particular effect, it is referred to as selective. But if it's X and Y, or alpha and beta type of properties of the drug has, then it's considered non-select. All right. So these are your non-select. So what these drugs do is block the stimulation of both the alpha and beta adrenergic receptors. And so wherever those receptors are, this drug blocks both. All right, be that the heart, the blood vessels, and so forth. And of course, this will cause the peripheral vasodilation, which means that, for example, in hypertensive patients, this will cause the blood pressure to be lower because the blood vessels are being dilated. Some of the examples is carvedilol, I think this is Coreg, and also labetalol. All right, these are your alpha beta adrenergic blocking drugs. The main thing with this is, if you're in the hospital, nursing home, what have you, you're preparing to give your medications, is to know that you need to know what your patient's blood pressure is. The blood pressure, the heart rate, you need to know what it is before you give it. You also need to know their history, right? Because they have a history of diabetes, they have a history of hyperthyroidism, then you need to know that. All right, because again, these drugs can mask those symptoms. All right. So carvedilol is given for hypertension and also heart failure patients because it does help to reduce the progression of the disease. Why is that? Because if I can dilate the individual's arteries, then the heart is not working as hard to pump against such a small arterial lumen, right? Or we want to increase the size of the artery so that the heart is not pumping too hard against all that resistance, all that pressure. Labetalol is given to gestational hypertensive patients alone or in combination with another drug. So your mothers who have gestational hypertension, this drug would be helpful for them. They may also give a diuretic with labetalol. And of course, as we know, diuretics, it will decrease the intravascular volume. So when we decrease volume in our intravascular space, we get a lower blood pressure. So they may use both of those drugs in combination to try to achieve their blood pressure goals. All right. And so the look at the adverse reactions for this particular drug: fatigue, dizziness, drowsiness, insomnia, weakness, diarrhea, dyspnea, chest pain, bradycardia, hypertension. Remember, when we decrease the blood pressure too much with these drugs, it can bring about many of these symptoms that you see, and also skin rash. That's probably a hypersensitivity to the drug itself. Um, So some of the contraindications, hypersensitivity, of course, bronchial asthma. Remember, some of these drugs have beta 2 receptor effects. The lungs, the bronchial smooth muscle on the lungs, and when it's blocked, of course, these patients can go into bronchospasms. Decompensated heart failure, meaning the person's heart failure has gotten worse, and also severe bradycardia. They would be contraindicated because these particular drugs will drop your heart rate. You don't want the heart rate to drop even more. All right. Take a look at some of the precautions: drug control, heart failure, chronic bronchitis, impaired hepatic and cardiac function, diabetes, and of course your pregnancy, lactation. So we're going to skip the interaction table, take a look at that, and let's go to now. These are your all right. So these are your centrally or peripherally acting adrenergic blocking drugs and what have you, the actions. All right. All right. Now, one group of anti-adrenergic or sympatholytic, whichever one you want to use, drugs inhibits the release. These drugs it inhibits the release of the norepi, that catecholamine, from certain adrenergic nerve endings in the peripheral nervous system. See, some of the this norepi is also in some of the nerve endings, and so these particular drugs prevent the release of that norepi. Right now, this group is composed of peripherally acting, meaning it's acting on our peripheral structures. All right, not the central, as in the brain spinal cord, but our peripheral, everything outside of the brain and spinal cord. Now, so an example of the peripherally acting anti-adrenergic drugs for treating high blood pressure is Minipress. That's one of the drugs. All right. These drugs are also used to treat BPH because what happens with BPH is the bladder neck, around the bladder neck, around the prostate, it is tight. And if you give these drugs, it causes them to be more dilated, and these patients can pee a lot easier. Now, another group of anti-adrenergic drugs is called the centrally acting anti-adrenergic drug group because they act on the central nervous system rather than on the peripheral nervous system, meaning central nervous system, brain, and spinal cord. Right now, this group affects a specific CNS or central nervous system centers in the brain and spinal cord, rather than on. Well, I said that. What I meant to say is this group affects specific CNS centers in the brain itself in the spinal cord, thereby decreasing some of the activity of the sympathetic nervous system. Now, although the action of both types of antiadrenergic drugs is somewhat different, basically the result is pretty much the same. And an example of one of the centrally acting antiadrenergic drugs is clonidine, or we also call it catapress. Clonidine or catapress. All right. Some of the uses or why we do use it for cardiac arrhythmias. All right. Sometimes cardiac arrhythmias make they some of them cause a heart rate to really be increased, and so these drugs would really be helpful in that respect. Also, we use it for hypertension, obviously, to cause that vasodilation effect, as well as BPH, as I just mentioned. And this is an example of what I was talking about. You got in this area where you have the prostate that is around the bladder neck. This is the bladder, and this is the bladder neck, as you can see. And what happens is it's tight, and so after you give this drug, it has a way of opening this up. It relaxes the bladder neck and allows one to pee a lot easier. Right. Some of the adverse reactions is hypotension. Remember, we're dropping the blood pressure. Drop the blood pressure, we decrease perfusion to our muscles and whatnot, so we experience weakness. We decrease blood flow to our brain, so we experience lightheadedness. And we also are dropping the heart rate as well, bradycardia, with these drugs because they have both effects, the alpha and the beta um, properties. Right. Now, these are some of the general adverse reactions for the centrally acting anti-adrenergic drugs like the clonidine. That causes dry mouth, drowsiness, sedation, anorexia, a rash, malaise, and also weakness. Right. Some of the contraindications. Number one, we already know the first bullet point. Also, it can cause active peptic ulcer or ulcerative colitis, and they specifically are speaking to the drug called Reserpine. All right. Now, Reserpine works by depleting catecholamines, such as like your norepi, from the nerve endings. It um, stops the catecholamine from being released, right? So it works by depleting that particular catecholamine from the nerve endings, and this can result in a decrease in gastric motility, right? So the bowels are not really moving, and it also causes an increase in gastric acid secretions. And of course, this can worsen the symptoms of a peptic ulcer that is already there. You don't have the motility, and also you have this increase in gastric acid, which can actually destroy the tissue, the where the ulcer is located, whether someone has a peptic ulcer or ulcerative colitis, and so causes a lot of irritation to the GI tract, and it causes the ulcer to either flare up or become even worse. Right. And of course, take a look at the when we would be cautious with renal and cardiovascular issues, and obviously pregnancy and lactation seems to be always a given. The contraindications for this drug is active hepatitis, and also antidepressant therapies using MAOIs. Right. And as far as caution, obviously those with renal and liver disease, because this is where drugs are metabolized and also excreted, and obviously lactation and pregnancy. We'll skip the interaction table, take a look at that. All right. All right, so we can kind of move a little further quicker. All right. All right. So remember, with the pre-admission assessment, we're looking at the baseline. Well, how did this patient present? Because we want to know if the therapy of the treatment modalities that we're using, are they working? Is the patient getting worse? Is the patient remaining pretty much the same? And so with that information, then we can make adjustments to our plan. All right. So as far as the objective data, I will have you guys look at that information that I have written here, so I don't spend too much time on it. Um, but one of the things I did want to mention, where it talks about vital signs, both arms and orthostatic blood pressures. If y'all don't know this by now, sometimes a physician may want to know if a person is orthostatic, because let's say if somebody's complaining of dizziness, well, it could be because the patient is orthostatic. And what that means is we take a blood pressure in both arms while the patient is sitting. Well, usually the patient is supine or lying down flat. Then we take the blood pressure, then we allow them to sit up. We take the blood pressure, and then we allow them to stand, and we take the blood pressure again. And remember, I told you that that top number should not be, it should not decrease more than 20. If it does, it probably would give the reason why this person is orthostatic, and that's how we characterize it, or how we um, uh, use that particular concept. The patient is orthostatic. All right. Take a look at the objective data. We certainly want to get as much information as possible, especially from the patient's experience. As far as ongoing assessment, all right. So it is important to perform an ongoing assessment on these patients receiving the adrenergic blocking drugs. This assessment often depends on the reason the drug is administered. So, for all adrenergic blocking drugs, it is important to observe these clients continually for the appearance of adverse reactions, be that they might be mild. Whereas others, such as diarrhea, may could cause problems with these patients, especially those who are older and debilitated. Now, typically, hypertensive clients will be asked to monitor their own blood pressures between visits. So while they're at home, hopefully they have a blood pressure cuff. I mean, they're fairly inexpensive, but if not, they can go to a pharmacist, or they can go to the fire department, and they can take their blood pressures. All right. Now, if a client gets a significantly different reading when using a public machine, um, the patient should ask the folks where they're getting the blood pressure done, whether it be at one of the stores or the fire department, when the last time their machine was calibrated, because it could be something wrong with the machine. All right. Take a look at the nursing diagnosis: impaired comfort related to drying of secretions secondary to medications. Some of these medications, they do cause dry, like dry mouth, if you will. Ineffective tissue perfusion, perfusion related to hypotension. These drugs can cause hypotension, low blood pressure. You have low blood pressure, then your mean arterial pressure is going to be low, and so your organs and tissues are not being perfused. Injury related to vertigo, dizziness, weakness, and syncope secondary to hypotension. And this is why you see some of those symptoms. And let me show you all something real quickly. All right, so you know how when we're looking at a drug and we see that the drug can cause a hypotension, right? We see that as like maybe a side effect, or in this case, an adverse reaction. And so just looking at hypotension, you can ask yourself the question: when someone is hypotensive, what is actually happening? Well, their blood vessels are dilating, right? And the blood pressure is dilating, and rather, the blood vessels, the arteries are dilating, causing the blood pressure to decrease, because this is what these drugs do, right? So if the blood pressure is dropping, that means your mean arterial pressure is dropping also. It means that you're not getting enough blood flow that goes out to your brain and to your muscles and to the rest of your organs and tissues. And so this hypotension or low blood pressure will result in what? Vertigo, dizziness, weakness, right? Muscles need oxygenated blood as well. So, so you can pretty much guess that if one of my um, if one of my side effects is hypotension, I don't necessarily need to memorize all the rest of some of the rest of those side effects or adverse reactions because anyone with hypertension, they will likely have or experience rather vertigo, dizziness, and weakness because of that reduction in blood flow to your muscles in your brain and so forth. So just kind of giving you another way of looking at this information. um, you can pretty much figure out what some of the other side effects would be just by looking at one of the main side effects, which is hypotension, in other words. So you take a look at that one, the planning when you get a chance. Um, all right. Right. So most adrenergic blocking drugs may be given with food. All right. So that's something to really remember when you're doing your tests. Now, but sotalol, which is a beta blocker, is given on an empty stomach because food can affect the absorption of the drug. So that one in particular, you have to remember, possibly for your test even. All right. Now, it's important to note that the drugs preventing the release of the neurotransmitters, these anti-adrenergic drugs, remember that non-selective alpha and beta type of drugs should be taken at the same time each day because of the fluctuation in blood levels can affect the blood pressure. So if you don't give this drug at the same time of day, then those blood levels in the body they will be up and down, and of course you won't be able to control this person's blood pressure like you should be able to. So giving it at the same time each day is going to be important to maintain those therapeutic levels. Right. Now, when adrenergic drug blocking drugs are given to patients to control their blood pressure, or if they have angina, which is the chest pain, and also cardiac arrhythmias, it is important to communicate with a healthcare team about the client's or the patient's response to that therapy. All right, especially if the condition is worsening. Right. Now, if the drug is administered for hypertension, right, so I just read that one. For some reason, that ended up on this one. Right, so beta adrenergic blocking ophthalmic preparations. These patients, if they're taking this drug for like glaucoma, the patient must continue follow-up examinations with the ophthalmologist, where the intraocular pressure can be measured. Remember, that's how they determine if someone has glaucoma. Um, let's see. One of the drugs they use, the beta adrenergic blocking ophthalmic preparations, is like timolol. Yeah, timolol. It's used for patients who have glaucoma, and it is important to do those periodic follow-up visits to the ophthalmologist to make sure they can determine whether or not it is effective or not. Right. Now here I'm going to, let's see, I'll just check to see if there's anything significant because you guys usually read this on your own, but some things I do like to point out just in case, especially if I feel like it's really something you might see again, if you know what I mean. Let's see. Um, Again, sometimes these patients, they one of the adverse effects is dry mouth or mild constipation, and so this can cause issues with comfort. So we must manage these side effects or adverse reactions. Um, Now, keep in mind also that even though the adverse effects might be rather mild, but they can be still pretty distressing for patients, and so we want to make sure we address them as much as possible. Um, and there are some simple nursing measures that we can take in order to provide, you know, um, more relief for these patients. For example, telling the patient to sip water or suck on a piece of candy, a hard candy, that can relieve the dry mouth. So we have to think about some of the things that we can do to provide some relief. Right. What some of the things that we can do to relieve the constipation, as you all already know, we've talked about these drugs, is high fiber diets and also fluids, unless it's contraindicated. If you got a patient with end-stage renal disease or heart failure, we have to be careful about recommending fluids. And so we have to know our patient's history. These patients you can suggest the doctor prescribe a laxative or a stool softener. These patients should also be monitoring their bowel movements, especially we should maintain a record when they're an inpatient, but also when they're uh, being managed in the community. All right. Lessen GI symptoms by administering drugs at a specific time in relation to meals, food, as well as antacids. So we have to know when the best time to administer, these medications. All right. Ineffective tissue perfusion. Um, And here, again, you may be asked to do orthostatic blood pressures. And so we can talk about that more in case you guys are not familiar with it. During therapy, take the patient's blood pressure on the same arm before each dose is given and recorded in the MAR. Some of these systems won't allow you to get the medication without, putting in a blood pressure. All right. And you all know about the orthostatic blood pressure. So just take a look at some of the other information I wrote here. Uh, let's see. So taking apical pulse and blood pressure before giving propranolol. I think that's the Inderal. So when you do it so in other words, you're not taking a radial pulse. You have to get your stethoscope and place it on the apical part of the heart and listen to the heart rate for a full minute. All right. And and of course, if the pulse or if the heart rate rather is less than 60, um, and if the heart rhythm is also irregular, or even if the systolic blood pressure is less than 90, we do not want to give it. And hopefully, the physician will provide some parameters in the chart to tell you these things, of course. Now, clients with life-threatening arrhythmias may receive an adrenergic blocking drug such as propranolol, and sometimes we give it by way of IV, especially when the situation is rather urgent. You'll see these drugs administered in the IV form, and of course, we have to monitor their cardiac rhythm throughout the therapies. Their blood pressure, respiratory rate, and so forth. See how they respond essentially. Right. Again, must take that blood pressure for 1 full minute. All right. This is not one of those you listen to the heart rate for 15 seconds and however many beats you get in between that time, and you multiply it times 4. Not in this case. Digoxin, propranolol, other medications where you're supposed to take apical pulses for a full minute. Make sure you do so. One reason for that is if you only do it for 15 seconds and the person has an irregular rhythm, it may speed up sometimes while you're taking it within that 15 seconds. But the duration of that time, up to a minute, you might have some irregularities in the rhythm, the heartbeats. And so you may not get a full 60. All right. It may seem like it's going to be more than 60, but in actuality, it may be 55, for example. Right. So you want to do it for a full minute. All right. So clients receiving an adrenergic blocking drug may experience postural orthostatic hypotension. They may sit up, feel dizzy. They may stand up, feel dizzy. So we hold it if there's a drop in 20. Um, um, if the value, let's say if somebody has 140 systolic blood pressure and it drops to um, let's say 120, then we this is where you want to hold that dose. Or if the systolic number is less than 90, we hold it and we notify the physician. Now, where it talks about minimize the first dose effect, if indicated, by decreasing initial dose and administering at bedtime. So the physician may give a lower dose and want it administered at bedtime when the person will be lying down anyway. I guess the only problem would be if the patient gets up to go to the bathroom. But typically, you give it about this time, the patient might, sleep all night and, let the medication does its job without them getting up and falling. Or if you gave it during the daytime, when they'll be likely up more walking around, they can sustain injuries. But the physicians rather, or healthcare provider, will slowly increase the dose over 2 weeks and allow the person's body to get used to the drug. All right, that's what that's all about. And of course, we place the call light in place, all that business. Let's see, instruct the person. Uh, let's see where it talks about instruct the client to rise slowly and provide assistance with getting out of bed or to a chair. Place the call lights close to the patient's bed and instruct them to call for assistance, right? Even give a male a urinal, and they may be able to urinate at the bedside. Instruct the client to sit or stand for 1 minute before rising or ambulating. So this is kind of like dangling on the side of the bed until things kind of just level out and stabilize, and then they can get up. All right. Let's see. Teach the patient to avoid hot showers, baths, or standing in one place for a prolonged period of time, because hot showers and baths actually vasodilate your blood pressure, and you're given these medications, it can cause a significant drop in the blood pressure, bringing about hypotension, and the patient can injure themselves as a result. Let's see. Let's see. So now we're educating the client and family. Let me see if there's anything in here. Uh, Financial. Keep in mind, some patients, they may have some financial issues and they may not have a pharmacy benefit even. So make sure you refer them to social worker who can tap into the various resources. Educate the client regarding the cardiac conditions that can occur if a beta block is stopped suddenly. All right, that's really important to tell them. Um, Thought about the primary care provider, stress importance of diet, weight loss, and therapy of hypertension. There are other ways to decrease hypertension or lower manage someone's blood pressure. And of course, we certainly want to instruct these patients to, be involved in a weight loss program. DASH diet is important, of course. That's a diet for hypertension. Observing, well, the rest of this you guys can read. I don't see where this is. Or inform the dentist and other providers about adrenergic blocking drugs. Monitor blood pressure in the home setting. So have to ask these patients, do they have a blood pressure machine at home? Let's see, what's that? I was like, so then we evaluate, of course. Let's see, is that, yeah, we evaluate the patient to see if things we've turned things around. Uh, and I think, yep, that's it. That's it, folks. So let me stop sharing and see how many minutes I have on this. All right. So this is about an hour and 30 minutes. So not too bad. But you can you can speed this up. As I said, I'm going to put it on a YouTube platform, and so you can speed it up. Maybe able to take 45 minutes. Anyway, so that's about it. I appreciate you guys listening. Let me know if it helps or not. Thank you.